Welcome, everyone. Thank you for attending our Gutsy Learning Series event on accessing treatment for Crohn's and colitis. My name is Ushani Kanagendran, and I am the Regional Patient Program Specialist for Central and Prairies, and I'll be the moderator for this event. Before we kick things off, let's go over some technical details. This session offers audio in both English and French. To access the French audio, click the interpretation option, the globe icon in the Zoom menu bar, and select the French language. If you encounter any technical issues, try refreshing your website browser or restarting the Zoom webinar. Alternatively, share your concerns in the Q&A box in the Zoom menu bar, and we'll try our best to assist you. I'd also like to acknowledge the rich history and heritage of Canada's Indigenous people. From coast to coast to coast, we acknowledge and we recognize the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Through this acknowledgement, we express respect for the traditional territories of Indigenous communities and contribute to the promotion of reconciliation. Next, I'd like to issue a disclaimer. The content in this presentation by Crohn's and Colitis Canada is intended solely for educational purposes. While the information holds general value, it may not be applicable for specific medical situations. Online resources should not be seen as a substitute for the personalized judgment and care provided by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during the webinar. I would like to share our commitment to the IBD community if this is your first time joining. Our commitment is to find the cures for Crohn's disease and ulcerative colitis and to improve the quality of life for everyone affected by these diseases. Through research, education, and advocacy, our organization strives to enhance the lives of both children and adults affected by these chronic diseases. We appreciate your interest in our organization and hope to make a positive impact in the lives of our IBD community. If you or someone you know is living with Crohn's disease or ulcerative colitis, we invite you to explore our Gutsy support events. These virtual sessions offer an opportunity to engage with individuals who understand the challenges of living with an inflammatory bowel disease, providing a platform to seek advice and understanding. We have various peer connect and caregiver events in both English and French happening throughout the year. You can find the details about the upcoming events listed on the screen here and register for them at crohnsandcolitis.ca/connect-events or by scanning the QR code on the screen. Now, let me welcome our speakers for today's event. We are thrilled to welcome our speaker for this evening, Dr. Noelle Rohatinsky and Shanta Zerak. First, we are very happy to welcome back Dr. Noelle Rohatinsky. Dr. Rohatinsky is an associate professor and registered nurse at the University of Saskatchewan. In 2018, Dr. Rohatinsky received the Crohn's and Colitis Canada Ross McMaster National Unsung Hero Award and has been volunteering with Crohn's and Colitis Canada for several years. She has led newly diagnosed nights to individuals in her community and nationally via our webinars. Her research focuses on enhancing health service delivery and access to care for individuals and families affected by IBD. Dr. Rohatinsky herself was diagnosed with Crohn's disease in 2000. Next, I would also like to welcome Shanta Zerak. Shanta is a senior professional in the pharmaceutical environment. She has experience as a clinical pharmacist, insurance drug plan manager, and pharmaceutical market access professional. Shanta has extensive knowledge of the healthcare, insurance, and drug environment in Canada. Thank you both for being here today to help us raise awareness on this important topic. Dr. Rohatinsky, please take it away from here.
Great. Thank you so much, Ishani. And thank you everyone for joining us tonight. We are going to start off with talking about what is inflammatory bowel disease. So we will be going through a short overview. Inflammatory bowel disease is an umbrella term for two diseases, Crohn's disease and ulcerative colitis. And here the key or the commonality between these two conditions is inflammation. So inflammation of the digestive or the gastrointestinal system. And it's that inflammation that disrupts the body's ability to absorb absorb nutrients, digest food, and eliminate wastes in a healthy manner. So when we take in food, it starts to be broken down in our stomachs, and then the food is transported to the small intestine. And the small intestine is not so small. It's upwards of 15 feet long, and its job is to absorb nutrients. And then the food will travel next to the large intestine. And the large intestine is around 5 feet long, and its job is to absorb water. So when there's inflammation in the digestive system, some common symptoms are watery, loose stools, or malnourishment. And so that could reflect that inflammation in those particular areas of the digestive system. Individuals with IBD have periods of time where their disease is active, where what that means is that there's active inflammation within the digestive system. This is also called an exacerbation or a flare. And there are also periods of time where the disease is not active or inactive, and that's also termed remission. And the goal of treatment in therapy is to get that disease, the IBD, into remission. That's the goal. And when that inflammation is not present, then the disease is inactive. So what's the difference between Crohn's disease and ulcerative colitis? Crohn's disease can affect anywhere in the gastrointestinal or GI tract, from gum to bum, so from mouth to anus. And that inflammation can occur through all layers of the bowel wall, from the innermost to the outermost layer. And you can see on the picture on the right-hand side of the screen, under Crohn's disease, that there's areas of redness, and they look patchy. We call those skip lesions. So with Crohn's disease, there's patches of inflammation, and it's intermixed with patches of healthy tissue. Whereas with ulcerative colitis, the inflammation is only in the large intestine, and it's only in the innermost layers of the bowel. So where the stool actually runs through the digestive system. You can see on the picture on the right, when we look under ulcerative colitis, that the inflammation occurs from bottom up, meaning from anus and rectum upwards in a continuous motion. So you can see that there's a bit of small differences between the two types of inflammation, but again, two types of diseases, but the commonality is that inflammation. How common is IBD? Well, Canada has one of the highest rates of IBD in the world. Over 322,000 individuals live with IBD, and that number is expected to rise. Even by 2035, they're expecting that number to rise to 470,000 individuals living with IBD. The disease can affect males and females equally, all age groups, although the younger age group, the children and adolescent age group, is we're seeing a lot of new diagnoses in this age group, but it can affect all ages, and it can affect any race or ethnic group as well. What causes IBD? The short answer is we don't know. But the research is showing that there are several linkages that contribute to the development of IBD. So there are some individuals who are more likely than others to get IBD. So we call them genetically predispositioned. So they're more likely, due to their genes, to develop IBD sometime in their lifetime. These individuals interact with something in the environment, and we're not sure what that something is in the environment, and it's likely a combination of factors. That something in the environment impacts the gut microbiome. So the gut microbiome is a collection of microorganisms living in our digestive system, and we have trillions of a variety of multiple organisms living within our digestive system. And the research is showing that there are changes to individuals with IBD in that gut microbiome. And it's those changes in that gut microbiome that cause an altered immune response that triggers that inflammation in the digestive system. So it's a very complex process. And there's lots of research is going on right now with what are the causes of IBD, but we just don't have it quite pinned down just quite yet. Very briefly, we'll be covering the commonly used medication to treat IBD, and it's important to just remind everyone that the goal of therapy is to reduce that inflammation within the digestive or GI system. And there are a number of medications available, and that number is continuing to increase, which is great news for those of us living with IBD. All individuals will react differently to medications. And so what works to decrease inflammation in one individual may not work in another individual. And sometimes it takes a bit of time to find the right medication that decreases the inflammation for the individual living with IBD. And it's not uncommon for individuals to be on more than one medication at once as well. So let's just briefly go into the different types or the drug classes. So the first one are the antibiotics, and there's a lot of drug names listed on the screen there, but some examples are the metronidazole or ciprofloxacin, and these medications are used to decrease infection that can cause or result from inflammation. They can be used with both individuals who have Crohn's disease or ulcerative colitis. And I just want to mention that every medication has side effects. So on every slide here, you will see that there are a list of side effects for each of these medications. And individuals might not experience all of these side effects or any of these side effects, but all medications do have side effects. So I just wanted to make note of that as well. The sulfasalazines and the 5-aminosalicylates are another type of drug class, and here these medications are used to reduce inflammation and can be used in mild to moderate colitis. And so we generally, don't use it for Crohn's disease, but I'll use that term generally because there are exceptions, of course. The other drug class are the immunosuppressants. And some examples there are listed. So methotrexate, azathioprine. and they suppress the immune system to reduce that inflammation. Can be used in both Crohn's disease and ulcerative colitis. And because it suppresses that immune system, individuals who are on these medications, it might put them at increased risk for other types of infections. So those would be one of the, a potential side effect. Steroids are commonly used, but they're not used for long term because of the side effects. So they work really well to decrease that inflammation quite quickly, but they're generally not used for long-term use. And if an individual starts to experience those signs of disease activity or that inflammation, they could be given steroids to decrease that inflammation. And then they might need to make changes to the other medications that they're on. Steroids can be used in both Crohn's disease and ulcerative colitis. And again, the side effects are listed there. The next type of medication are the Janus kinase inhibitors. Tofacitinib is an example, taken to reduce that inflammation as well. And it is used in colitis at the moment, not currently approved for Crohn's disease, but I know that they are working on doing studies related to these JAK inhibitors. And then biotherapies are the next class of medication. And so these are biologics and biosimilars, and there's a long list of these medications listed on the screen there. So adalimumab, infliximab, etc. Taken to reduce the inflammation, can be used in both Crohn's disease or colitis, depending on the medication. Some medications are only given in certain conditions. And again, side effects are listed there. Typically, individuals might see infusion site reactions, allergic reactions, or again, because we're suppressing that immune system, risk for infection. So I'm going to turn things over to Shanta, and she's going to talk a little bit more about the biologics and biosimilars.
Perfect. Thanks so much, Noelle. I realize that there's probably a slide missing here that we didn't sort of talk about biologics in general. So I'm just going to give a little bit of a quick overview on that and talk about sort of why these drugs are so special, so expensive, and just go into a little bit about the different classes that we've got right now. So these were developed sort of the late 90s and the early 2000s. And these are really large molecules, which is why they are given by an injection or an infusion. And they're very, very specific. So they fit into, the proteins in the body in a very, very specific mechanism. And thus they reduce the rest of the side effects that Noelle was talking about. In terms of some of the other medications, these biologics are very, very specific in their action. So they can reduce inflammation without some of the other side effects that can happen with the other disease-modifying therapies that we use. But they are very, they're developed and they are produced very differently. They are, biologics are actually they're isolated or manufactured using living organisms. So they're done using cell lines, they're produced in bacteria, and they're used also recombinant DNA technology. So when these drugs were first developed, they were, there's a lot of expense and study and research that had to go into them before they were able to be used for, especially in the markets. So when they compare them to sort of an aspirin or, some of the other molecules that were mentioned, it's very, very small to a very, very large molecule. And they're very, very complex to produce. So the manufacturing facilities in terms of the chemical conditions that have to be met and the physical conditions. So that's sort of the reason why there is so much attention paid now to what we got in the biosimilars. So I'm not sure in terms of when the patent runs out, of course, on a medication and it's a small molecule, we have generics entering the market. When the patent runs out or the exclusivity period of exclusivity runs out for a biologic molecule, we have the introduction of the biosimilars. Now, Health Canada did a lot of work with biosimilars and they have been used all over the world. So they've made a couple of statements that I've sort of listed here on this slide in terms of the safety and efficacy of the biosimilar drugs. So it's highly similar. They do not call it interchangeable, as you will see with a generic molecule. They call it highly similar to the biologic drug that was already authorized for sale. It's a much more rigorous process for the biosimilar to be approved in Canada than a generic drug. They have not seen, and in order to receive the label of biosimilar, it has to make sure that there's no clinically meaningful differences in safety and efficacy between the originator biologic and the biosimilar. Next slide, please. So this is just the reference that they had did, the peer-reviewed study that there's been more than 178 clinical trials worldwide involving approximately 21,000 switched patients, and confirm that switching from an originator biologic to a biosimilar drug is not associated with any major efficacy, safety, or immunogenicity issues. So this is something that Health Canada also will share with anybody who has concerns about the biologics, the originator biologics and the biosimilars. Next slide. So this is just really quick, and it reinforces the slide that Noelle shared in terms of the biosimilars available in Canada that are specifically used in the Crohn's and colitis disease states. So the originator drugs, we had Remicade, Humira, Stelara, and Enbrel, and there are biosimilar products for these in Canada. Stelara is just at, it's in the review stages right now. So depending on your coverage, which I'm going to talk about later, and depending on who you use for your insurance, you may be have to be switched to one of, if you're currently on one of these biologics, originator biologics, you may at some point in time have to switch to a biosimilar. If you are new to biologics, you are more than likely going to start on one of these biosimilars. Next slide. And this is just a little bit of a note about what I just mentioned in terms of non-medical switches. So, and by non-medical switch, it means switching from an originator biologic to a biosimilar for no other reason than cost savings. So biosimilars are less expensive to the insurers and drug plans than the originator biologics. So most of the public plans in Canada have biosimilar policies and programs in place that require patients to switch to the biosimilar within a certain period of time when it's introduced to the market. Private plans and employer plans really only require new patients to start on the biosimilar version of the medication. If you are currently on an originator molecule with private insurance, they will keep you on that molecule. They will not require you to switch. Now, switching between biosimilar and originator biological products, or between different biosimilar products, should remain a clinical decision made by physicians and patients, should be determined on an individual patient basis, and supported by scientific evidence, and performed only with patient awareness. So this is something that you would discuss with your physician. The public payers who have implemented these switch policies do have exception processes in place to allow patients to remain on the originator drug. And I think, Noelle, I hand it back to you now.
Great. Thank you, Shanta. So now we're going to just talk briefly about monitoring of that inflammation. So a lot of them, when we are on these medications, they do require regular monitoring. So I just wanted to talk about the importance of that regular monitoring. The monitoring frequency really depends on the person, the individual living with IBD, how they're feeling, and the medication or medications that they're on as well. So it depends on the test for monitoring as well. So there's a lot of variation in terms of that monitoring frequency. But it is not uncommon to have that regular monitoring because of the medications. Some of the blood tests that can be looked at while somebody's on these various types of medications look at the level of inflammation within the bloodstream. So it gives us, the provider, a sense of how the body is responding to that medication. Is it decreasing that inflammation within the body? They'll also monitor blood cell levels in terms of the red blood cells, the white blood cells, the platelets, because some of the medications can change those blood cell levels, and so they would want to keep a close eye on that. The liver and the kidneys are impacted by the medications, or specifically the liver helps to process the medications. The kidneys will help to eliminate the byproducts and the wastes from the body. And so we want to see those, assess that level of liver and kidney function. If there are changes in liver or kidney functioning, the medication dose might have to switch, or the drug might need to be switched itself. So they do want to keep a close eye on those levels. Vitamin and mineral levels. Some medications can change the vitamin and mineral levels in the body, and so they'll want to keep a close eye on that, as well as medication levels, drug levels, to make sure that the drug that they're giving is maintaining that good or therapeutic effect to decrease that inflammation. So those can all be done by blood tests. Other types of tests are stool tests. One of the more common ones that you might see is the fecal calprotectin test. And that test measures the inflammation in the intestines. It's not specific to IBD, but it will say, will indicate that there is either an increase or a decrease in that inflammation within the intestines. So again, it could be used to determine how that medication is working to decrease that inflammation. So, has it gone down? We would expect that inflammation to go down with treatment. Or is it rising and maybe a medication change needs to happen? There's also endoscopy. Endoscopy, there's 3 other words listed there. So gastroscopy, colonoscopy, sigmoidoscopy. What that is a test or a procedure that uses a small fiber optic tube with a light and a camera that's either inserted through the mouth of the patient or through the anus and the rectum of the patient, and will look at the digestive system. And so then the provider can look visually inside the digestive system to see that level of inflammation, and also to take tissue samples. And I know that it can be a bit challenging to have regular monitoring. It's sometimes you may forget to get regular blood work. It's life gets busy sometimes. So I think it's helpful if you can put reminders in a calendar to get that regular blood work. Or I know it's not comfortable to have the colonoscopy. I think the prep is probably the worst part of it. And same with the stool test. Some individuals are not comfortable with collecting a stool sample, but it does give the provider a lot of information as to how those drugs are working within the body. So my plug is to continue with that regular monitoring as needed, as recommended by your provider. Very briefly, we'll talk about medication administration tips. So taking that medication regularly minimizes the chance of that flare-up or that inflammation in the body. And so it's important to remember to take those medications. And it's important also to recognize that some of these medications may take time to decrease that inflammation. So it might take, for some medications, it might be a few days. Others, it might be a few weeks, or even, a few months. So it does take time. But if you're feeling like, I don't notice any difference, talk to your provider and, ask them, what is an expected length of time? When should I start to feel better? Because sometimes these medications can take a while to have you start feeling better. It's always great to keep a list of the medications. Often individuals may be on more than one, and it's hard to keep them all straight. So that medication list is really important. And again, just sending those reminders, whether it's in your calendar or even having them visible maybe on your counter if it's safe to do so in your household, or just as a visual reminder, oh yes, I have to take my medication today. Take them at the same time of the day, and perhaps with another activity like, first thing in the morning or right before bed. And if, some medications, they're large pills, or maybe they come in an enema form where you have to insert it in the rectum. And so some ways in which we give these medications may be uncomfortable for you. Talk with your prescriber, your healthcare provider, or your pharmacist about alternatives to these medications. If you are challenged by the current medication that you're on. Another great suggestion is the use of blister packs. So if you have multiple types of medications, the pharmacy can group them together. These are the pills to take in the morning. These are the pills to take at bedtime. So that's a great alternative as well. And storage of medications, just to be mindful that some medications require certain storage. So things like some of the biologics and biosimilars, they need to be kept in the fridge, for example. So just to be mindful of that as well. And if you're unsure, to ask your provider or your pharmacist. Briefly, we are going to be talking about physical and mental wellness. It's I really do believe that physical and mental wellness plays a part in IBD management. And one of the most common questions that individuals will ask or have questions about is diet or nutrition. And the short answer is there's not one magic diet that works to decrease that inflammation or to cure IBD. Here, the key is to eat a well-balanced diet. Following the Canada's Food Guide is a great strategy. Some individuals, of course, will want to limit certain foods. So there are some foods that individuals with IBD may limit because they cause GI symptoms or digestive symptoms, so abdominal pain, bloating, diarrhea. So over time, as an individual learns what their own body's like, they might think, oh yeah, when I had that coffee, I just had to use the washroom right away. Or when I had that spicy food, it made me really bloated. So there are common trigger foods, things like caffeine, spicy foods, things like processed meats. Lactose intolerance is quite common. When an individual is in a flare, eating smaller, more frequent meals is helpful, and making sure to eat nutrient-dense foods and limiting those processed foods, the sugary foods and sweets, because that can increase symptoms. Fiber is okay, except if you have a stricture, which is a narrowing of the intestine, either due to swelling or to scar tissue, or if you are in an active flare. But don't be afraid of fiber as well. But the Crohn's and Colitis Canada website has a wonderful resource on the website about foods. It's listed there, as well as there's been many webinars about diet and nutrition with IBD. So I just wanted to highlight the other elements. Fats are appropriate, especially if you find that you're decreasing, losing weight. The fats are a good source to increase that calorie intake, and protein with every meal is important. There are certain diets or supplements that might be needed. And again, with the guidance of a dietitian, which is very important, you might entertain trying some of these diets out. But again, because they are quite restrictive, making sure that you are engaging with a dietitian for direction and advice in case there's other supplements that are needed as well. Exercise considerations as part of therapy as well. It's okay to exercise. Light to moderate exercise is appropriate. not only improves physical, but also mental health. And you can see the recommended activities and the length of time listed on the screen there. But, you know, do what you like to do. You don't want it to be a chore. Listen to your body and start slow. If you are having a flare where that inflammation is active, you might want to reduce maybe the length of time or choose gentler activities. So maybe it's just walking, right, or stretching when you are in a flare. The gut and the brain are connected, and there's lots of research happening around that gut-brain connection. And we know that stress, anxiety, and depression do not cause IBD. However, people with IBD are more likely or at an increased risk to have anxiety and depression. And some individuals find that stress can increase disease symptoms. So if you're feeling particularly stressed and you're having, say, more diarrhea than usual, more abdominal pain than usual, there is that link there. So mental health is so important. It can impact our quality of life. If there are mental health challenges, they could cause more severe symptoms, have higher rates of treatment failure, and cause an increased risk of surgery. So it's important to maintain our own health and wellness strategies, taking care of ourselves, and just again, it's easier said than done, but eating healthy, getting enough sleep, exercising, all those activities. Connecting with others is so important, and whether it's connecting with friends and family or others with IBD can help to create that sense of community. It can be quite isolating with IBD and feeling like you're alone, but you're not alone. And what's helpful can also be to volunteer through Crohn's and Colitis or other community organizations to feel that sense of purpose. Avoiding alcohol, tobacco, other drugs, because that can make symptoms worse or also can alter mental health. And creating that wellness plan, meaning, okay, what things should you do, on a daily basis to improve your wellness? What things should you be avoiding on a daily basis to improve your wellness? And, don't be afraid to ask for help when needed. And I think there's a little bit of still some stigma as well with mental health, but I think it's improving. And so don't be afraid to ask for help if needed. Finally, I just would like to talk about some general support resources. So there are many support resources that Crohn's and Colitis Canada has, and it's important to build that support system from family, friends, partners, or professionals. And the Crohn's and Colitis Connect is an online community where individuals share their experiences. Individuals can be paired with mentors who live with IBD, who know what it's like to experience those symptoms and have those experiences. And it allows for a place to find those credible resources. There are other Peer Connect events, just as Ushani had mentioned at the start of the presentation, where these are live sessions similar to what we're doing here, where you have that ability to interact in a live way with individuals living with IBD. And there's also one for care providers as well. There's local Crohn's and Colitis chapters that you can become involved with if you want more of that community level. The Gutsy Learning series are, I see that's twice on the screen there, but Gutsy Learning series and webinars have such a wealth of information, lots of experts presenting on a variety of topics. And finally, the MyGut app, which is a application that's free to use and to download, where you can track your symptoms and how you're feeling, provide you with educational resources, and you can share that with your provider if you want. So that was a very short synopsis of the different types of ways in which we can maintain our mental, physical self. I'm going to turn things over to Shanta, and she's going to be talking about an overview of the drug coverage in Canada.
Thank you so much, Noelle. And Noelle is going to be driving my slides for me. So much appreciation. I couldn't quite get my presentation mode to work. So if you just want to flip through to the next slide, which is just the disclaimer, we can skip that one and go on to the next slide. So I'm just going to give a little bit of an overview of the outline of what I'm going to talk about here. So I'm going to talk about a little bit about who pays for drugs in Canada, formularies and how new drugs to Canada get onto formularies, talk a little bit about specialty drugs, and then we're going to talk a little bit about the patient journey on specialty drugs. So this is really good, diving deep into the specialty and biologic and biosimilar medications that I talked about a little bit earlier. It also applies to some of the medications that Noelle mentioned, where there are, coverage and who covers what drugs and how they get covered. So it does apply to all drugs, but I'm going to focus on the specialty drugs and the biologics and the biosimilars. If we have time, might do a little bit of a pharmacare discussion. I know that's been a hot topic as of late. And so, I'll give you my view on what has been happening and what is going to, sort of be the next little while with that. So if we just move on to the next slide. So, I'm going to start with who pays for drugs in Canada. So drugs in Canada, as many of you may know, drugs fall outside and have fallen outside of the Canada Health Act since its inception. So for people to get coverage in drugs, unlike other countries that have a single payer system, drugs fell outside of that single payer system. So they're not covered in the same mechanism as you would find in some of our European countries and European counterparts. And we have a mix of public and private coverage. So here we've got the chart, and under public coverage, what is included in there is all of the provincial drug coverage programs. And so that could be the pharmacare program in Manitoba and Saskatchewan. It could be ODB in Ontario, Alberta Blue Cross government plans in Alberta. There's also obviously the territorial regions also have coverage, and then there's also federal coverage. So for NIHB coverage, for the Corrections Canada, for RCMP, they're all covered under what we call the federal programs, which is under the larger umbrella of public drug coverage. Private plans is really anything that is offered through your employer. So most employers that offer benefit plans will offer drug coverage, and that's what we consider under the private insurers. So there's hundreds of private insurers in Canada. The big three that we have are Canada Life, Manulife, and Sun Life. And of the 26 million people that are covered under private plans, those big three cover probably about 60% of the people under those plans. Also included in here is what we call individual coverage. So if you are self-employed, you might want to go and get and purchase sort of an individual health insurance plan. So you would purchase a plan that has a prescription drug program, might have a little bit of dental, might have a little bit of vision. So that you do have some coverage. And this is also available through most of the big insurers and the Blue Crosses and everything like that. So private drug plans, of all of the money that's spent on prescription drugs in Canada, they comprise about 37% of the spend. And then the other part of it is the household or the individual is paying out of pocket, or what you pay for your deductible or your co-insurance. Next slide. Oh, looks like a repeat. Skip that one. There we go. So let's talk a little bit more about public drug coverage. So every province and territory have drug coverage available for its residents. However, there's great variability in who is covered, what's covered, and how much is covered. Generally, we split them into sort of three broad types of public drug plans. So we have the pharmacare type that's found in BC, Saskatchewan, and Manitoba. We have what's called catastrophic type. So this is only after all other avenues of coverage have been exhausted can you access this plan. So that would be the Ontario Trillium Plan. And some of the Atlantic provinces have catastrophic drug programs, PEI, catastrophic drug program, for an example. And then there's a couple of provinces that have what we call premium paying type. So New Brunswick and Alberta, you have a public drug program, but you pay a premium similar to what you would pay for an employer-sponsored plan. So these are sort of the three different broad buckets. But like I said, the coverage can differ in terms of how much is covered and what is covered. Now, for vulnerable populations and for those that are on income support and children in care and things like that, there are always public plans have a vulnerable patient coverage, and every province has that as well. You want to go on to the next slide. We'll talk a little bit more about private drug coverage on this slide. So these are generally offered as part of your employee benefits plan. Again, it varies widely between employers. So you might find a large employer or, say a government employer offering a more comprehensive benefit plan, as opposed to a small business who can only afford to offer, a smaller, more restrictive benefits plan to its employees. But they do, in general, tend to be more generous than the public plans in terms of the number and types of drugs that they offer. So, for example, you might find on the public plan in a certain drug category, only 3 drugs are covered, whereas on a private plan formulary, you may have a choice of 5 or 6 or 7 drugs on there. It's very important to keep in mind with these private drug plans, it's considered as part of the overall benefits plan. So it's not just, drug coverage is sort of one piece of the benefit plan that employers use to attract and retain employees. I'm going to go on to the next slide there for me, Noelle. So this is just really quickly talk about employee compensation, and kind of you go way down into the supplementary health benefits, which is on the 3rd level there. That's really where the drug benefit sits. So when we talk about challenges in the private drug plans, we have to remember that employers that are offering these, it's part of the overall compensation package that they're looking at when they're looking at what individual drugs they are adding to their benefit plans. Next slide. All right, so let's talk a little bit about out-of-pocket costs. So in the previous slides, when I talked about the variabilities, there's also variability in what out-of-pocket costs can be on both the public and the private plans. So these costs can include deductibles or copay, and or if you live in Quebec, it's a combination of both for their publicly funded drug plan. So deductible is the amount that you have to pay before an insurance plan kicks in. So if we use Manitoba, for example, they have Manitoba Pharmacare. In order to access the formulary or to access your coverage, on Manitoba Pharmacare, you have to have spent a certain amount out of pocket before you reach that coverage level. And it's based on your household income. And it's also based on having a medication that qualifies for that deductible. So that means it has to be on the Manitoba formulary. Your private plan formulary that's going to help you cover that deductible tends to look very similar to the public plan formulary, so that at the appropriate level, the coverage can flip from your private plan to your public plan. Copay is usually either offered as most often as a percent. So it's a percent of the total prescription cost. So a prescription cost, as many of you probably know from the pharmacy, it includes the cost of the medication, the markup, the pharmacy markup, and the distribution markup that the pharmacies charge, as well as the dispensing fee that the pharmacy charges. And then a certain percentage of that is your out-of-pocket cost. And there's some nuances in there. You'll have limits on the amount that your insurer may pay for, or the public plan may pay up for your dispensing fees. You might only have the pharmacy may charge you $12 for a dispensing fee, and your coverage might only be $8 on your dispensing fee. So there's a lot of variability when it comes to sort of that piece of it as well. Next slide. So this is just some quick facts for you, and this relates to some of the challenges that we have in Canada, and contribute to that pharmacare conversation that I sort of briefly mentioned at the beginning. For people who have significant medication burden, the out-of-pocket costs can be significant, and they can be a burden on the patient and the family. So these costs are not only associated with the prescription drug costs, there's also all of the indirect costs that are associated with having a chronic disease that aren't covered by anybody. And so they're simply, out-of-pocket costs. So indirect costs are estimated at least 1.51 billion in 2023. We have the indirect costs of unemployment and costs of absenteeism and presenteeism, which, if you're suffering from a chronic disease that doesn't allow you to work on a regular basis, and your employer is paying for somebody else to be there, or they're paying you sick time, these are also indirect costs that you can't recoup. We have the caregiving costs for children with IBD, estimated to be nearly 58 million. And Canadians with IBD pay 536 million out of their own pockets to obtain care, medications, and supportive therapy not covered by any of these drug plans that I talked about. Next slide. So some of these, and I mean, this is not an exhaustive list. So, we have them, and we're going to talk a little bit about some of the medications here in a bit and how they get on the forms, but there are always going to be medications not covered by insurance. Most significantly, anything that is over the counter is usually not covered by any insurance plan. The allied health services, they have psychologists and some of the other care mechanisms that Noelle talked about in her presentation are not fully covered. So even on generous private plan insurance, you may not get full coverage for a psychologist. You may only get a certain amount of money that goes towards it every year. Supportive therapies, the vitamins and supplements, transportation to medical appointments, and parking are some of the ones that have come up really recently. And if you have frequent visits to places that require parking charges, especially at the hospitals, it's extremely expensive. Noelle touched on the mental health care and taking care of your mental health. And if you need professional help within that, very rarely is that going to be fully covered by any of the insurance plans that are in place for private insurance. And there are very few supports in terms of the public plans and out-of-pocket costs for that. So it's really anybody with a chronic disease, for all of these indirect costs, it becomes a real challenge to try and sometimes access these because of the barrier of not being able to afford them. Next slide. So I'm just going to go backwards a little bit here. And I mentioned a formulary before, and so we're going to talk about a little bit of about what a formulary is. So it's a list of drugs, really. And not every drug that is approved for sale in Canada is going to be paid for by either the private or the public system. So what ends up happening is, for our pharmaceutical manufacturer partners, is they submit a drug to Health Canada to be approved in Canada, and Health Canada is going to look at it and ask two questions. They're going to ask, is it safe and is it efficacious? And if the answer is yes, they're going to grant authorization for sale of that drug in Canada. But that doesn't mean that that drug is going to be covered by any of the insurances in Canada. So there are quite a number of drugs that aren't covered by either private or public, but they are available in Canada. You would just have to pay out of pocket and pay cash for those medications. What ends up happening after that is that the manufacturer is going to send sort of a package to the public payers and the private payers, asking for consideration to be put on the list of drugs that they will pay for. And these review processes can take anywhere from 6 months to 2 years to complete. So Canada has been called out a number of times for being very slow in reviewing new and innovative drug treatments, and especially in a disease state such as Crohn's and colitis, where it's very important that there is an armamentarium and additional therapies for patients to access once they have failed therapies. And there's only so many drugs, and like Noelle put so clearly before, in terms of the different types of drugs that we have, we want to make sure that there is a continual pipeline of new drugs for patients when they fail on some of the medications that we have. So Canada lags a little bit behind in how quickly these new drugs get to market and how quickly they are added to the formularies. So once the private payer or the public payer reviews these, you really have 3 outcomes. So it's going to be approved as a general benefit. It's approved with prior authorization, which I'm sure many people here have had experiences with, and I'm going to talk about that a little bit. Or it could actually be denied, depending on how the payer feels about the cost of the medication and the placement in therapy. Manufacturers do engage in confidential negotiations with both the public and the private plans in order to get their drugs on formulary. So the manufacturers work very, very hard to try and get these new medications into the hands of patients as quickly as possible, but the process itself can just take a long time. And next slide. These are some of the terms that everybody has probably seen before. So we talk about the formulary category. So again, on both private and public, we have traditional drugs, and many of the drugs that Noelle mentioned, and the antibiotics, some of the disease modifying agents, the 5-ASA products, we would consider as traditional drugs. The category of sort of specialty drugs and biologics and innovator drugs are terms that are used to really refer to the newer innovative drugs that are quite expensive. So, the average cost of some of the biologics used to treat autoimmune conditions, they're anywhere from $25,000 to $35,000 per patient per year. So you can have some of the specialty drugs. So she mentioned the JAK inhibitors, which are actually small molecule, but they are around the same price because they're a specialty drug. They're around the same price as some of these biologics. Then you have generic drugs, and generic drug is a very specific term, and it does refer to a generic product authorized by Health Canada that is an exact copy of a small molecule. So it is quite a specific term that we use. You have vaccines. And then there's also supply. So on a lot of the formularies, they have included, there's diabetic supplies, there's ostomy supplies. In the private side, there's variability in which of these products can be covered, as well as variability on the public side. Sometimes the public payer will pay for these through a different mechanism, and sometimes you're able to pick them up at the pharmacy. Next slide for me. Okay, so we're going to dive a little bit deeper into what I just said about the specialty medication. So specialty drugs is not a defined and it's not a term that everybody has, it's not an agreed upon one line. So there's some common characteristics of specialty drugs, and it usually includes, there's a complex treatment regimen that could require ongoing clinical monitoring and patient education. Again, Noelle referred to the labs and the monitoring that has to happen on these specialty medications. That becomes even more important for patients to follow. Many of them have special handling, storage, or delivery requirements. So the cold chain, as it's called, has to be maintained for these drugs. So they have very specific temperatures at which they must be stored through their entire journey to the patient. They can be injectable infusion, or like I said, there are a few specialty molecules that are oral as well. Sometimes they have limited availability and distribution, and that usually is in relation to either the cost of the medication, or it could be because of the special handling and storage requirements of the medication. They treat individuals with less common and rare diseases. This is changing a little bit. So when biologics, again, when they were first introduced in the sort of late 90s and early 2000s, the first indication for Remicade, I believe, was rheumatoid arthritis. So it was a smaller patient population, it was a very defined disease state. But because of the efficacy of these drugs and how well they do work once that sort of magic lock and key is discovered, they're being used to treat more and more diseases. So as we discover the reason behind many disease states, there are developments of biologics that are very, very effective for these disease states. So some of them, there are now biologics for migraine. That is a much more common disease state. And there are biologics for cholesterol, again, something that is is more common than the autoimmune disorders, and where we traditionally use biologics and biosimilars. The last line, higher cost than traditional small molecule drugs. That's almost 100% guaranteed that these newer drugs come to market with a very, very high price tag to them. Next slide. So many specialty drugs, most specialty drugs require prior approval from the payer, both on the public and the private side. And these forms are going to, and I'm going to take you through a really sort of a little bit of a patient journey on what happens when your prescriber decides that this is the right therapy for you. But the payers are usually looking for some common types of information. They're looking for a confirmation of diagnosis. They're looking for some lab results. Will be looking at prior medications, and they're going to be looking at some of the clinical assessment tools that are out there for these disease states. So they want to make sure these drugs are not used at this point in time first line. So they want to make sure that you've tried some of the prior medications and have maximized the benefit from the traditional medications and the less expensive medications before moving on to these more comprehensive and expensive medications. And next slide. Okay, so really quickly, I'll take you through what could be a typical patient journey when it comes to these specialty biologic medications. So when you see your healthcare provider, when you see your specialist, and the decision is made, and with your involvement that it's time to move to one of these specialty medications. The physician is going to decide on that specialty medication through his experience, your individual characteristics, some of the side effect profiles of the medication, the delivery mechanism. Are you somebody that can and are able to go to an infusion clinic and have an infusion, or do you live in a more remote area where delivery of an auto injector is easier and more convenient for you? So once the prescriber decides that you've decided on the type of medication, either biologic or biosimilar at this point in time, all have what we call patient support programs in place. So what happens is the prescriber fills out a form and sends this enrollment to one of these patient support programs. And at that point in time, and there's a little bit of a gap here. So for patients, it can be a little bit of an uncomfortable period. There's a little bit of a lag time, but the patient support program then takes over, helping to get you onto the drug. So getting the drug into your hands and getting you started on the medication. So the physician has sent the enrollment form and the prescription. And then what's going to happen is you're going to get a phone call from the patient support program, and they're going to ask you a ton of questions. So they're going to be asking you about some of your prior medications that you've had before. They're going to be asking you, more importantly, or just as importantly, they're going to be helping you navigate your reimbursement. So the private payers and the public payers that I spoke about before, a lot of times patients and people don't know a lot about their drug coverage until they have to use it. So the patient support programs that are out there help you navigate with the payer these prior authorization forms that I talked about before. So they're going to help fill them out. They're going to go to your physician on your behalf, get him to get the information onto those forms and get it sent out to the appropriate payer for them to do the assessment. Some of these drugs in the meantime, and not all of them, but some of these drugs have what we call bridging programs. So they may provide you with free medication in order to get you started. So you might then get a phone call from a pharmacy or from a clinic to say that we are ready to either deliver your medication or we're ready to set up an appointment for you. If they're going to be delivering your medication and you're new to injectables, and this is not something you've ever done before, you're going to be given, some options in how you want to sort of be educated on this and what your comfort level is with giving yourself an injection. So They might do it over, they might send you like a training video. They might, in certain circumstances, they might have a nurse visit your home. You might be able to do it at your local pharmacy. The pharmacists, the scope of practice of many pharmacists across the country has grown, and they will be able to help support and show you how to self-inject using these pre-filled syringes or the auto injectors. Appointment scheduling is done at one of the clinics that's going to be in your area, that's going to be close to you. So the patient support program is going to help you through all of this, but it does take time. So it's one of those things that you may, you're anxious about receiving a prescription for this specialty medication. This is all new to you, and they are there to help support you. But you just have to kind of be aware that there might be some, 1 or 2 days or 3 or 4 days where you're not hearing from somebody. So the other person you're going to hear from, or the other sort of group you're going to hear from, is going to be the pharmacy. So it's going to be either the pharmacy associated with the patient support program, usually a specialty pharmacy who handles these types of medications all the time. So they're going to phone you and they're going to ask you a bunch of questions as well. And they're going to help set up, where your preferred delivery is, or, for some of these medications, you're able to pick them up at your local pharmacy, or they can eventually be transferred to your local pharmacy. So all of these are sort of pieces and parts of what you're going to experience as you go through if you are put on one of these specialty medications. The other thing the PSP provides is, ongoing support and are there for any questions. And they'll be checking in on you for what's very, very important with these drugs. And again, Noelle had mentioned it, is adherence and making sure that you're taking your dose. A lot of times with these medications, what can happen if you don't take them as per the schedule is that they start to lose their efficacy, and eventually they may not work for you. So it's very, very important. And so the patient support program and the pharmacy are there to help you. So there are times when, and I work in this area, and I know that some patients, they get annoyed by the number of phone calls that they'll get, because they're getting calls from, they may even get a call from their insurer. So it feels like a lot coming at you, especially in the beginning. Be assured that all of the phone calls and the questions are necessary. And it is just to make sure that you get on therapy and that your experience with the medication is going to be sort of as good as possible, and that you have resources to be able to reach back out if you have any issues with that. Next slide. All right, that I see is the last slide that I've got. Thank you, Noelle, for being an awesome slide turner, and I'm going to hand it back to Shani.
Thank you so much, Shanta and Dr. Rohatinsky, for the wonderful presentation. The knowledge you have transferred to everyone today is highly important. We are going to move into the Q&A portion of tonight's event. So for our viewers, if you have any questions, please comment in the Q&A box found in the Zoom menu bar. And if we cannot answer your questions, then please also do take the time to email learn@crohnsandcolitis.ca, and we can answer your questions there. Just a quick disclaimer, we cannot answer questions about specific medical situations. With that, I'm going to go into the first question. So this question, Shanta, I'm going to direct at you. Given the potential for fewer side effects with nutritional supplements, why do you think there is a limited research on their efficacy as treatments for Crohn's and colitis?
So I'm going to tag on to a little bit of what Noelle talked about earlier in terms of the nutritional supplements. So I'm going to talk and just hone in a little bit on the limited research on their efficacy. When pharmaceutical manufacturers bring drugs to market, and we've heard the cost and the time associated with bringing a drug to market in the clinical trials, and the good manufacturing practices. And I talked about, how biologics are produced to make sure that it's reproducible and that every single dose is exactly the same. there's no there's no incentive for nutritional supplement companies to do that same sort of research, because that they already have significant profits and sales. So why would they spend the money to do that? And I don't mean to sound I don't mean to sound negative on that, but there really is there's no incentive to do the research, and the little research that has been done, and probably the reason why nobody has then furthered it is that the research wasn't strong enough and didn't support it as a sole treatment for the efficacy in the disease state. So nutritional supplements and the anti-inflammatory diets, they can be good for your health overall, but they are not a replacement for pharmaceutical medication for these disease states, and the pathophysiology and mechanism of how these diseases come about that Noelle very clearly showed in her presentation. And I'll invite Noelle to sort of tag on to that comment.
Yeah, thank you, Shanta. That was well described. I think, I think it's important that while nutritional supplementation can be helpful because some medications will maybe deplete or change the nutritional levels within our bodies, that really they aren't as a replacement for the therapies that we've talked about today. I think, I think it is, while they might have, less noticeable side effects, I think the key here is that we make sure that we are using the therapies that have the research to decrease that inflammation. And at this point in time, we just don't have that much information about those nutritional supplements.
Thank you for the insight. I'm going to move on to the next question. What resources or strategies do you recommend for patients to educate themselves about medication risks and benefits? And I'll open the floor to you both.
I can maybe start, and then Shanta can carry on. I think, I'm going to put a plug in for pharmacists, because they are the experts in medications and side effects and have all the credible resources available to them. So I think even, there's a lot of medications out there, and I think our healthcare providers, our GI providers, have a wealth of knowledge and expertise in a variety of areas. But when it comes down to medications, I really think the pharmacists are the champions for having that credible, reliable access to information about the side effects, the risks and benefits, but also the healthcare provider team. So important. The nurses, the GI providers, like the physicians as well. They will have had lots of individuals living with IBD who are on these medications. And so the medication, the drug companies will provide those risks and benefits to the providers as well. So Shanta, I'll let you tag on to that the answer as well, but those would be my recommendations. Ooh, one more, the Crohn's and Colitis Canada website. Again, I absolutely, there's so much work has gone into that website to provide credible information.
Thank you for the plug for my profession. I much appreciate it, and I echo that. If you have questions about your medication, and even if you find something that you find something that you've been doing, and I discourage use of Dr. Google, but if you find something on Dr. Google and you have a query about that, take that information to your pharmacist. Don't be afraid to take something that you've found that you're not sure about, and they can look up through their resources, and they have, like Noelle says, not just their own professional learning and teachings and everything else. They have a plethora of the resources available through many of their subscriptions, and they know where to go to find the information that is valid. So I really, really highly encourage, and never ever stop your medications without talking to a healthcare provider, especially when it comes to autoimmune disorders, because stopping the medications can cause the disease to flare. And so it's very, very important that if you're experiencing, especially if it's sort of like you're not feeling well, bring it up, talk to either your pharmacist, your nurse. If you're on one of the specialty medications I talked about, there are nurses available through the patient support programs as well. All of the provinces have, I call it a 311, that you can talk to them about, but really try to go to those first and foremost.
And I just want to say, Shanta, I find that the pharmacists are more readily accessible and available than the providers. And maybe there's a lot of pharmacists out there, maybe that there's just more of them, but if you need a quick answer about, oh, this is new, I haven't experienced it on this medication, you might be able to get a more ready response and then follow up with your provider after that as well.
Yeah. And that's a great plug for getting to know your pharmacist.
Thank you, Shanta and Dr. Rohatinsky. I am going to jump into some live questions that we've gotten from some of our viewers. The first question we got was, are you able to talk more about seniors and Ontario deductible? Is there anything we should be aware of?
So the seniors program in Ontario, so the seniors benefit under ODB is actually, the deductible is I think it's $6.11. And or $2 is the basically the copay on the prescription. So the seniors program in Ontario is very, very generous, and that's really the maximum that you're going to pay under that program. So that's for Ontario residents that are 65 and above.
Thank you, Shanta. The next question is, right now we are getting a biologic covered by 100%. By the pharmaceutical company until alternative funding is secured. Should I be worried at some point we might be on the line for $30,000 a year out of pocket?
No, you do not have to worry about that. The pharmaceutical companies, when they introduce these compassionate programs, they are ethically and morally, they will support you on that medication, regardless of whether the payer kicks in or not. They have made that commitment, and that is part of the reason why so that some of these ancillary services that the pharmaceutical companies provide through the patient support programs, the government is well aware of them, and don't. Pharmacare is something that might upset that apple cart. So that's another reason sort of why we really are very, very careful when it comes to the pharmacare. So going back to your question, no, absolutely. The pharmaceutical company, when they start you on a compassionate drug, they are de facto making a commitment to support you on that drug through your journey on that drug. For those of you who are on the line who have had experiences with multiple biologics, eventually most people end up switching biologics 2 or 3 times. So, you might be on this biologic for 2, 3, 4, 5 years, and the pharmaceutical company, barring any catastrophic, I'm not going to make a guarantee, but I can almost guarantee you that they would support you through that entire period.
Thank you, Shanta. The next question we have is looking for some clarification on the One Path program and who coordinates the drugs. So this question is coming specifically from Saskatchewan. Does it mean that this drug company is sponsoring the drug instead of your province? If so, why would a company sponsor a drug with no pay?
That's a loaded question. It's a great question. So all of the patient support programs, and I don't want to speak to any individual patient support program because they're all very different, and but they are providing support to in an ideal world to supplement the coverage that is already in place. So there's a number of reasons why the payer in Saskatchewan may not be covering a drug 100%. There could be a dose escalation. There could be an off-label. So a lot of the clinical criteria that I talked about before, if as a patient you don't meet that clinical criteria, the payer may not approve coverage, but the pharmaceutical company may have, through their mechanisms, have compassionate support for that. So there's a number of different things that sort of play into that. But I'm going to go out on a limb here, and I believe most of the drugs currently in the market for Crohn's and colitis are covered by the government of Saskatchewan. I believe that their formulary coverage is quite good.
Amazing. The next question I have is from a PSP nurse. And they're wondering if you see any gaps between patient support programs, prescribing MDs, and pharmacists that you feel could be better addressed.
Yes, because we're all human. So when I talked about the patient journey there's a lot of, it's a high touch environment. It's in a high touch by people. So there's always going to be room for improvement in a general sort of sense. So, we could be the patient support programs could contact the patients quicker. The patients could pick up their phones quicker. The physicians could fill out the forms better. So there's always going to be improvements, but I think that everything with good intent. And I think the intent behind all parties involved in people, involved in supporting patients with autoimmune disorders, we work really, really hard to do that. And I think even with all of the challenges, I think we do a really, really good job in Canada, and, associations such as Crohn's and Colitis Canada also help to support that. So there are gaps. And many of the companies out there are aware of these, but we're also working to improve on them every single day.
Thank you, Shanta. I have one last question for the evening. What advice would you give to individuals with IBD that are struggling to receive adequate long-term support and care due to the current state of our healthcare system in Canada, i.e. the lack of family doctors, long waits to see your gastro, or follow up on issues and concerns?
Wow, that's a big question. I don't know if we have the answer to all of that important question. Ushani, the question was what suggestions to help navigate the oh brother. I think, I think it is try your best, of course, to get a family doctor, but for some people that is just impossible. There's wait lists for years and years, right? If you are experiencing health challenges, going to the walk-in clinic, like the same one every time if you can, so that they have your file there, not going from one to another where it may not be connected. And again, having all of your medications at the same pharmacy, or so just having that as much as you can have that consistency. I'll give some more thought to that, and I'll maybe turn it back to Shanta to share her resources and expertise. But I'll give that some more thought, because I think that's the magic question in my personal opinion. And we are in such a state of crisis in the healthcare system. So anyway, Shanta, go ahead.
Yeah, it's it's these, especially with these complex diseases that are, it's the genetic lottery. It's, you lost the genetic lottery, and it's unfortunate that we don't have the supports, the full support available that we would like. Being your own advocate, and it's a very uncomfortable thing for a lot of people to become their own advocate. And I think, educating yourself on some of the resources that are available. And I think on the Crohn's and Colitis website, there's a lot of resources available to use and a lot of reach outs that you can use. But, echoing what Noelle said, consistency in the pharmacy, talking to your pharmacist, if you don't have a family doctor, and if you can get into a walk-in clinic, realizing there are challenges with that in certain jurisdictions as well. Tracking your own symptoms, keeping a diary of your symptoms, keeping a diary of what is happening with you, your medications, all of that kind of stuff. It's a big step for people to become a patient. And there's the help that is out there. You have to reach out for it as well, and you have to become your own advocate. And I know that is way easier said than done. And I wish, there was an easy solution. Oh, you just phone, 1-800 or whatever, and you get a family doctor. And we all know that there are certain regions, especially if you're outside of a big center, where that's just not possible.
And I think I just want to add that, as living with IBD, you know your symptoms, you know your body the best. And so I just want to also highlight that if you feel like, okay, something's changed, maybe you feel like the medication is not working as good as it once did, or you're not feeling well, that, you know yourself the best and you have that expertise. So to follow up as well, to just continue to be your own advocate and bring that to the provider and keep going back, right? Be that squeaky wheel, because no one else can do that, and I think it's easy. The system, you can get lost within the system quite quickly. So just to yeah, I think all of the suggestions would help. But just if you are feeling unwell, continue to advocate to get some blood work done, or oh, it's been 10 years since I've had a colonoscopy because I haven't had a provider, like, so that they can see the inside of your intestine. So just to really be that advocate. So great suggestion, Shanta.
You too.
Thank you so much to the both of you for that insight. I do have one last question before we sign off. So this question is asking if you have to switch to a biologic and don't have drug benefits anymore, will they still be covered, or will they have to pay out of pocket?
That's an individual case-by-case question. So very much a case-by-case question. Your healthcare provider, though, a specialist, are the most knowledgeable as to which program to direct you to that could potentially help you out.
Thank you, Shanta. And with that, I'm going to close out our live Q&A. Thank you, everyone, for your questions. And if you do happen to have more questions, please feel free to reach out to us at learnandcrohnsandcolitis.ca. And once again, Shanta, Noelle, thank you so much for joining us and sharing all of your insights. We do have one quick poll question. How would you rate your current knowledge of accessing treatment for Crohn's disease and ulcerative colitis? Thank you for answering the poll questions. Please let us know how we've done today and what you'd like to covered in future events. There is a 60-second feedback questionnaire at the end of the presentation. A prompt to complete the survey will appear on your screen directly after this event. A special thanks to BG Communications for the live French interpretation. We really appreciate you taking the time to be with us as well. Lastly, you can follow Crohn's and Colitis Canada at Get Gutsy Canada, and that's on Facebook, Twitter, YouTube, Instagram, and TikTok. Thank you all for joining us tonight, and I hope you all have a good night.